mediastinal shadows are within normal limits. Stop. The lung fields and pleural reflections are clear. Stop. No pneumothorax. Stop. No concerning osseous abnormalities. Stop. Excuse me, Dr. Gill. Could I please discuss a request with you, please? My consultant says it's really urgent, so is it okay? Could you please take a look at this? What's going on, guys? Jazz here and welcome to another video. So I know there's this preconception that radiologists like to sit in a dark room and, basically get off on rejecting scans all day, but that is not entirely true. Now, what I think most people don't realize is that a radiologist or a radiology registrar in a hospital is usually only one person covering the entire hospital during an after-hours shift. So every other department has, a ton of people, at least a couple of registrars, residents and whatnot that are all on the wards looking after the patients and taking care of all the jobs. But in radiology, there's usually only one or two people max on in an after-hours shift. So you can imagine if two people are taking care of the entire hospital's needs, it's a massive job. Now, the radiology registrar phone, that I have to say is probably the worst device that I've ever seen in my entire life. Now, if you think about every call that you make down to radiology during the day for a scan request, it's a lot, right? You think about how many different teams there are in the hospital, which is like dozens and dozens. Think about all those people also making similar volumes of calls, all down to the same phone. So you could imagine that it rings a hell of a lot. So if I think back to the times that I had the phone, if you think about call waiting in the phone, our deck phones or phones in the department would also have that feature, and usually we'd be getting multiple calls at the same time, that I would have kind of 3 calls backed up on the same while I'm talking to someone. So that annoying little beep 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 noise that you usually get when you've got another incoming call, that's essentially ongoing the entire time I'm trying to talk to a different referrer. So you can imagine at the end of the shift, there's nothing more that I want to do than throw that phone out the window. But unfortunately I can't. People wonder why are radiologists usually grumpy during the day, particularly the registrars in the hospital, and that is one of the biggest reasons that we're grumpy. So you can imagine doing your job, say you're in the emergency department, you're a resident or a registrar or whatever, and you're going to see a patient. You're going to see the patient, you're taking the history, you're doing your physical exam, blah, blah, blah. Now imagine if somebody came in and interrupted you every 12 seconds to ask you a question or to ask you to do something. Can you review this? Can you come and see this? Is it okay if we do this? Oh, I've got another, 20 patients for you to see now. Can you come do this? Or can you check this list? It gets pretty bloody annoying, right? So that is in its essence what a radiologist or radiology registrar deals with every day. And you can imagine through an entire shift, so say if you do a 12-hour weekend shift, you're pretty over it by the end of the day, right? And from the radiologist's perspective, getting all these referrals, it's already painful as it is, but when you continue to get poorly made referrals, which are incomplete or don't provide a correct history or, the wrong studies being ordered, it makes it even worse. So in today's video, I thought I would go through some tips from a radiologist's point of view as to what you could do to make your referral better. And at the end of the day, that's just going to give you less grief, and the radiologist will just say yes to your request straight away and everyone will be happier for it. So my first tip is always introduce who you are and what team you're calling from. The number of times I've gotten phone calls where someone just starts rambling on about their patient or some sort of history or something irrelevant, it happens all the time. And they'll kind of keep talking for a while, 20 seconds have passed, and I'm kind of waiting just to cut in to be like, well, sorry, who are you? Like, what team are you calling from? Just so I can kind of, understand Is this an ED scan? Is this something that's going to have to be done urgently? Is this an outpatient scan that, getting called about for an oncology outpatient scan that you actually want done in a month or something? Or, is it an inpatient that's, critically unwell in ICU or something like that? So if you introduce yourself and kind of tell your level, are you an intern, are you a resident, are you a registrar, are you a consultant? That's all part of, kind of risk stratifying the referral that I'm going to be getting. And then obviously what team you're from, and then we can get going. And also, it's just common courtesy. Like, you don't call people normally and, you don't introduce yourself. Like, it's just what people do. Number 2 would be, what scan do you want? Like I said before, instead of just jumping straight into the story or, irrelevant information, it's always good to mention what scan you're after. Are you looking for an ultrasound? Do you want a CT? Do you want an MRI? Are you actually looking for an interventional procedure or angiography or something to be performed? Because a lot of the time, particularly in the hospital, when you're calling through a switchboard, the switchboard will generally just put through everyone to the one phone number. It might not be the correct phone number, but they've got one number written down for a radiologist, and they'll put everything through that, even though it might be the wrong number. So a lot of the times, like I've been called and I'll be reporting, purely emergency department scans, and someone's been put through to my phone in emergency, and then they kind of go on to try and request something without, giving me a second to let them know that, I'm actually just covering emergency, and if you want an inpatient study, then you actually have to speak to someone else. And always remember, radiologists are medical imaging specialists. We know a lot about scans. We spend years and years studying about what scans you need to do for what pathology, etc. It's kind of insulting sometimes when some people will be like, oh, I need this scan with this contrast in this phase and whatever. Like, I get it. Like, you might understand or you might know what you're looking for, like, what phase you need to do. But at the end of the day, it's something that, me or the other radiologist are going to decide anyway. Because, we have to interpret it. We know what phases are correct to exclude the pathology. So rather than you telling me that, I need this scan with whatever, you're better off just saying, look, I'm trying to exclude this. And then, we're going to do the right test anyway to exclude that pathology. But if you just say, I want this contrast in this phase, and then I'll be like, but why? The next tip is only provide relevant medical history and relevant blood tests. A lot of the times we'll get calls and it ends up being a bit roundabout before we actually get to the point. And like I was saying before, everyone's busy. So if you streamline everything, it makes it easier for everyone. So only mention the stuff that's relevant to the actual current presentation. So, like, I don't need to know the patient's social history in the context of getting a scan, or, that they had this disease that's not relevant, 27 years ago, but it's nothing relevant to the symptoms that they're presenting with today. It's always better just to be like, if you think it's appendicitis, then tell me that, I'm looking for appendicitis, this patient's got, right iliac fossa pain, rebound tenderness, their white cells, inflammatory markers, everything are up, they've got fevers, we think it's appendicitis. That's it. So the more succinct and better thought out the actual referral and information that's provided on there, the better. My next tip is just to be polite. Radiologists are people too, and I think a lot of the time people forget that we're specialists as well. So some of the referrals that we get are usually half-baked, or, they're not at the same quality that, junior doctor or a registrar or something from another specialty would call another team with. So a lot of the times we'll get a request like, a full body scan, and they've provided us with no history, no bloods, and the clinical questions like, query pathology. Now, I can imagine that you would never call the neurosurgery reg with the same kind of information. Like, it would just be unheard of in any other discipline, but everyone seems to think it's okay to give radiologists, crappy referrals essentially. So if you are nice and sure, I understand when you're a junior doctor, your seniors will just tell you to go get something done, and it can be a bit hard, especially when you're not sure why or you don't understand, and then obviously your story won't be as good when you're trying to relay it to the radiologist. But if you're polite, understanding, and if the radiologist asks you a question, that's not being obstructive or saying no. Essentially, they're just trying to find out what you're after and what kind of test we actually need to do to try and work out what's going on with the patient. And I think the last point would be to let us know how concerned you are about the patient. Because radiologists, we are actually sitting in a dark room, we're not out there seeing the patients. So we can't tell how urgent it is. So it's all right to be like, look, we're actually very concerned about the patient, they're probably going to need to go to theatre soon, or, something along those lines. Then let us know, because at the end of the day, every referral that usually comes in, it's all triaged by the radiologist. So it's not really a first come, first, scan kind of scenario. It's really, okay, you've relayed the referral to me, and okay, I'm like, all right, well, this sounds quite serious. Like, this is something that they'll probably need to act upon very soon. I'll give it a category 1, which means they'll scan it ASAP. Or, it's not that worrying. If they're coming through ED, like, we'll try and do it while they're there, or if we're too pushed, then it might be done once they get admitted to the ward, and that'll be a different category. So there's things like that as well. So I think it's important that you emphasize how concerned you are about the patient. So guys, those are my tips on how to make a better radiology referral, and hopefully if you put them into practice, will give you less grief next time you go down to the radiology department to get a scan approved. If you like the video, please give it a thumbs up, subscribe if you're new, and I'll catch you in the next one.